We would like to thank today's webinar sponsor, Milmick Insurance Company. My name is Erin, and I will be your host today. I would like to introduce our speaker today. Her name is Nan Gallagher from Gallagher Campanella, LLC. Nan has devoted her career exclusively to the advocacy of healthcare professionals and entities. An accomplished healthcare litigation and administrative attorney, she focuses her practice on licensing, regulatory, and credentialing matters in New Jersey and New York. Ms. Gallagher is a nationally recognized authority on groundbreaking healthcare topics, sought after for her dedicated focus on often controversial pro-physician platforms. In addition to various medical societies, she serves as general counsel to the Professional Assistance Program of New York and the medical staffs of Morristown Medical Center, Chilton Medical Center, Hackensack Meridian Health, Palisades Medical Center, and CarePoint Hoboken University Medical Center. In 2017 and 18, Ms. Gallagher was recognized as a super lawyer both nationally and in New Jersey in the field of healthcare. We're very pleased to have her with us today. Please welcome Nan Gallagher.
Thank you so much, and I welcome you all to this webinar. We're going to be talking about Medicare today, so I'm sure you'll find this a very scintillating topic, but a very important one because a lot of practices have been approaching our law firm as well as others, especially in the last year because of an uptick in Medicare audits. And a lot of practices are very daunted when they are faced with how to respond to record requests. What does this mean? What am I supposed to supply? How quickly am I supposed to supply these materials? What happens if I don't? What happens when I do? Am I going to have to pay money back? And all of these questions certainly tell me as a healthcare lawyer about the pressures and anxiety that can build in a medical practice, especially for the practice managers and the staff who are there to assist the physicians in trying to get these materials that have been requested out the door. And the doctor is busy, obviously, running the practice and also seeing patients. But from the practice management perspective, there's a lot at stake. So I'd like you all to approach this webinar with the perspective of what can we do to try to crack this Medicare code and understand the process to de-escalate the level of anxiety that comes along with these types of audits and appeals and overpayment demands. So I welcome you, look forward to educating you a little bit today on this, and certainly feel free to request slides or materials from the association, and certainly feel free to contact me if you have any additional questions. Without any further ado, I've already been given an introduction. This is all I do, healthcare law, and Medicare specifically is a federal law. It's a federal program. So even though I'm sitting during this webinar in New Jersey, and I'm also licensed in New York, the advice that I provide to you today crosses state lines. It is the same advice that I would give anyone sitting in Virginia, Connecticut, or any other state. And these are the rules that we all want to play by. So certainly, I don't want you to walk away from this saying, hey, well, she's a New Jersey and New York-based healthcare lawyer. What does this mean for me in my state? Everything that I'm going to be telling you today does apply. I do receive no remuneration from the association for this presentation. I am not paid at any point when I lecture, and I really am just focused on trying to get medical practices and practice managers in line with the best advice they can have so they never have to call me. That is my goal, that you never have to call me. So let's talk a little bit about Medicare and the audit process. When we think about Medicare, we think about several things. One, practices of physicians need to be credentialed with Medicare many times to remain on staff at hospitals, certainly to see elder patients. It is often a requirement to be credentialed at surgery centers to some private health insurance companies also do require a corollary enrollment with Medicare. So Medicare is, think of it like the key element that a doctor can have, the key piece of the puzzle. And if it goes away, if the doctor loses his credentialing with Medicare after he's had it, it is not so easily brought back, can't get it back so quickly, can have rippling effects on other areas of his or her practice. So when we get an audit request or a record request from Medicare, we take it very seriously because of what's at stake. There are certain risk factors that are triggered when a medical practice is getting an audit request from Medicare. Now, sometimes Medicare will show up at your practice unannounced. They are entitled under federal law to do that. I don't like that because I don't feel any practice should be ambushed by any federal or state program or any federal or state entity like an agency, a state board, etc. But Medicare can come unannounced and ask for records on the spot. So we always just want to be on guard if that ever happens. If it's Medicare, you do have to let them know. But as far as the risk factors that are triggers to potential document reviews and audits, I've listed them here for you. If the physician is a particular outlier, perhaps he is billing more Medicare beneficiaries for treatment during a given day than the typical doctor within his geographic zone. Perhaps he is using high-level codes which are triggering some type of raised eyebrow on the Medicare end. Somehow, a doctor who is billing aberrantly from other physicians who are also enrolled in Medicare, that can trigger an audit and often is the number one reason that an audit starts. So being an outlier matters. Also, improper coding or chronic miscoding. So it is very important, and we're going to talk about it, to have staff working at your practice or working for your billing companies that are preferably certified coders, but certainly if not certified, up to speed on coding developments within not only ICD-10, but also the local coverage determinations, being up on those things. Because when coding is submitted to Medicare that is improper or there's upcoding or miscoding, that can also trigger an audit. Sometimes, and although rarely, pharmacy sweeps where Medicare will go in and run an internal investigation at local pharmacies to see who's prescribing what and what Medicare beneficiaries are receiving what drugs. That can trigger an audit. Or the last two bullets you see here, dissatisfied patients or disgruntled employees. Both of those types of complainers can file complaints with Medicare as well as other agencies saying, oh, Dr. Jones is doing X, Y, and Z wrong, or Dr. Jones is saying he sees this many Medicare patients in a given day and he really isn't. That's something called the impossible day scenario. In other words, when a doctor is billing, it's fraud basically, but a doctor is billing for seeing more patients than he actually has seen during the workday. And Medicare is very keen to that, and they will look to see how much time you're spending with patients, whether it adds up to the actual workday. So these are the types of risk factors that trigger audits. When you talk about audits and what you can expect, this is typically how the audit will make its way into your practice. So we talked about ambushes. Medicare can show up and ask for records on the spot. But what happens more typically is a request that comes via letter to the practice from CMS or one of its contractors asking for records to be produced. So many of your practices may receive letters like that requesting records from Medicare. You may also be getting letters requesting records from private insurance carriers. There is definitely a growing trend of insurance providers asking for records. Do not be alarmed if the request seems minor, small, not so burdensome. Do be concerned if it is a vast amount of records requested, if it is repetitive in nature, meaning the same patient's records are being requested for different dates of service numerous times over the course of a period of months. If this is such a heavy-handed audit where they are requesting pages and pages and pages of records, that is a sign that you may end up getting tagged for an overpayment in time. So you want to just kind of put that in the back of your mind and say, okay, is this just a simple record request, or is this going to develop into something more problematic for us? Always keep copies of the records that you have provided. Obviously, we know not to modify records that we have provided or ever. Also keep copies of the requests that come in. Very important, so you can look back at trends and see, okay, this is the type of patient they're looking for. This is the type of code that was built for these patients. You can expect very vigorous follow-up from Medicare. So if you don't respond, you're going to get a letter in the mail saying we haven't received it. We'll give you one more opportunity. And that's why I tell everyone, take these requests very seriously. And also CMS provides a fax number typically for practices to submit records. If and when possible, I always encourage practices to fax records in, because faxing is essentially an exception to HIPAA requirements. I don't know why, but it is. So you can fax documents into CMS, and then you get your fax confirmation sheet. I almost called it a read receipt, but you want to have those fax confirmation sheets. Keep them. It is probably in the days of EMR the quickest way to submit records to CMS and to have a record that you actually did so. And what you can expect after getting voluminous record requests, if that happens for Medicare, you can expect to have to pay money back, or at least to be asked to pay money back. The look-back period for fraud is 10 years. Typically, CMS will look back about 5 years, sometimes less. But what they'll do is they'll ask for records, ask for records, ask for records. About a year down the line, Medicare will say to you, okay, we've looked at all these records and we think we've overpaid you in the amount of this. So we'll talk a little bit about how that conclusion gets communicated to your practice and what you need to do. I am not encouraging any medical practice to pay back money to Medicare without running that by, in my opinion, a healthcare attorney, because anytime money is paid back to Medicare or to a private health insurance carrier, it is essentially an admission of fault. That is how it will be deemed on the carrier's end. So I would strongly suggest checking with someone who specializes in this before you do pay money back. And then also they keep a record of it. So if you've paid money back once and then perhaps do the same type of miscoding in the future, if that is the case, Medicare will remember that 5 years later, and if they'll look back at your records and perhaps tag you again for more money to be paid back. Excuse me. Also, Medicare shares this information with private insurance companies. So if you're doing improper coding, whether it's an innocent mistake or otherwise, and you pay money back to Medicare, ultimately you may expect to hear from other carriers asking for money back. So don't be so quick to pay money back. When you have already submitted your records to Medicare, shortly thereafter, and that ranges from anywhere from 30 days to about 60 days, you can expect to receive the initial determination letter. This is the letter that says, we have reviewed these records, and we have determined that you are not coding properly these issues. And it will be explanatory. It will say what Medicare alleges that your practice has done wrong. If you have in-house billing, take that letter and talk with your staff about it and find out whether or not these allegations of Medicare are correct. Sometimes they're not, so always be dubious when you get an initial determination letter. If you have outside billing, you're going to do the same thing. You're going to make sure they're aware of this and try to get to the bottom of the summary of findings to see whether or not Medicare seems right or wrong, and also to formulate any response. I do not recommend getting an initial determination letter and doing nothing about it. And a lot of practices do that, and it leaves me scratching my head because we just, as a whole, never want to have a federal or state health program make a conclusion that we did improper billing and not refute it. It's always better to refute it, even if you ultimately lose. Always better to go on record having refuted that. So you're going to draw your own conclusions, think about what you had previously submitted, do your codes support, are they supported by the medical records, even consider potential experts, if you had to, in terms of what the allegation is. So, for example, if you are, let's just say you're a dental practice and Medicare, dental is a good example. If Medicare claims that something has been billed improperly, well, consider whether or not you need to find someone to recommend to you an expert who can defend not only the medical or dental treatment rendered, but also the billing that was submitted, et cetera. You want to be able to support medical necessity and the codes used, et cetera. So shortly after you get the initial determination letter, and that's often what is sent to me, practices will send that to me and say, here's an initial determination letter, what do we do? So I tell them all of these things, and then I say, you need to wait. You're going to get an overpayment demand. So the initial determination letter isn't going to tell you exactly what Medicare wants you to do. It's not going to tell you how much money they claim that you owe. That's for the overpayment demand letter, and that comes usually about 45 days to 60 days after the initial determination. Typically, this overpayment demand includes extrapolation. If you don't know what that is, here is the example. Medicare has looked at X number of records. It has determined that the wrong codes were used for these types of treatments or procedures. And it will say, well, we looked at these records, but let's presume over 5 years, statistically, that the practice would have seen X number of patients more and billed the same code. We're going to multiply what we found was a loss or an overpayment for the records we did look at, and we're going to multiply that through some type of formula that is way above my head, and say statistically this practice owes us more money because we didn't look at every record that they've ever submitted. So you can expect to have a component of extrapolation in that overpayment letter. Payment, once you receive it, is due very promptly. There will be a short timeline, and it varies, but you can expect having to pay money back to Medicare in as quick as 2 weeks and as long as about a month and a half. It'll say, please render payment at this time. At the end of the overpayment letter will be something that sets forth your appeal rights. I strongly emphasize that a practice should appeal any adverse initial determination and overpayment demand. So don't roll over. Don't pay money back. Simply appeal. So we're going to talk about the appeals processes for Medicare, but what I'd like you to take away from this presentation is challenge what they are claiming. Medicare, as much as people think it's all about helping patients and covering patients, Medicare is a business. It is a multi-billion-dollar business, and They're very quick to say you overbilled or upcoded on something, we want money back. And many times those determinations are overturned at various different levels in the appeal process. So you want to consider what you do need to do to challenge their allegations. When you challenge unfavorable audit results, which you should do, think about these types of things. And this is something a healthcare attorney can talk with you about. But do you need to obtain a statistician to refute this extrapolation that I explained? You probably should consider that. There are statistician experts out there who will look at the formula that Medicare applied and poke holes in it. And very often there are holes to be poked in Medicare's extrapolation formulas. So consider getting or having someone retain for you a statistician. Consider having an outside review by an independent coder, someone who doesn't work for you. There are many coding entities out there that do these outside reviews. Consider having someone evaluate the claims for medical necessity, if that is the issue. Was the treatment that the practice rendered appropriate? So that is something that another similarly situated medical provider or dental provider can provide to you. Consider any way to challenge what Medicare claims is missing from your documentation. So this is probably the biggest area that I find vulnerability with Medicare. Medicare will look at all of these records. They'll ask you for them. You submit them. Over time, they may ask multiple times, and then you'll get an initial determination that says, oh, we did not find X, Y, and Z in your records. And you get this letter saying, I know X, Y, and Z are there. Go through what was produced and find them. Circle them. Say, well, look, here is the history and physical. Here is my decision-making to support this code. Here is what I did here. Because I will guarantee to you, Medicare glossed over those records. So there are challenges from a documentation perspective to be made. And then consider whether there are any procedural challenges. Perhaps this initial determination draws conclusions about how treatment was rendered over what period of time, and it shouldn't have unfolded that way. Well, if you need to explain things procedurally, the care rendered was appropriate on this timeline, we would do that as well. So these are some tips on ways to poke holes in audit results. There are 5 levels of Medicare appeals. Here they are set forth in front of you. Redetermination is your first level. Reconsideration is your second level. The third level is colloquially referred to as the ALJ appeal, but it's also known as the third level appeal. The fourth level is before the Departmental Appeals Board, or DAB. DAB is the fourth level. And then the fifth level is before the federal court. That's judicial review. What you need to understand about these levels of Medicare appeal are the following. 1, many professional liability insurance companies now cover a medical practice for all or some levels of Medicare appeal. So if you do get an initial determination, or you wait and then ultimately get an overpayment letter, I would encourage any medical practice to refer that letter to the physician's professional liability insurance carrier. It is infinitely better to have an insurance company pay for a practice's attorney's fees than to have the practice pay it out of their own pocket if it is determined that an attorney would be helpful. So many times these Medicare appeals are covered. Second, think about these 5 levels and say the following. Levels 1 and 2, 4, okay, so 1, 2, and 4 are all essentially decided by Medicare. So to give you the example, Medicare issues an initial determination that's completely adverse to you. They're asking for money back. You should appeal. You will file a request for redetermination, and that appeal is decided by Medicare. So is the request for reconsideration. The reconsideration request is decided by a contractor of Medicare, as well as, excuse me, the Departmental Appeals Board level. That is also decided by a contractor of Medicare. So you ask yourselves, how many times has someone been able to change your mind in your life? I tell you that because from an appeal perspective, it is highly unlikely that Medicare or one of its contractors is going to reverse its decision at levels 1, 2, or 4. Medicare often will affirm its prior decision that your records were deficient or your coding was improper. What I encourage all practices to know and to do is to definitely appeal first level, second level, because you're likely to lose, and get to the third level. The third level, which is the administrative law judge, the ALJ appeal. That is your opportunity as a medical practice to get before an impartial arbiter of the allegations. And there is an entire division of the Administrative Office of Courts devoted to handling Medicare appeals. It is not associated with Medicare. It is impartial, unbiased. The ALJ appeal is your best chance, as is level 5. But if you get up to level 5, which is federal court, you're probably going to lose, because if you've had to go that far in the process of Medicare appeals, you've probably done something wrong. Not always, but it is more likely than not that if you have to get all the way up to level 5 of the Medicare appeal, that there's probably problems with your records or your coding. But the ALJ level is your best chance to have a fresh look by an independent person at what is alleged. And these ALJs with their law clerks will go and comb through all of the record codes, all of the submissions of coding, and figure out if you did something wrong or not. And more often than not, the ALJs will reverse the lower level Medicare adverse decisions. So you want the third level. The bad news about the third level, the ALJ appeal, is that when we get to that level, it takes forever. The current wait period that has been posted by, I believe it's Health and Human Services, but it might actually be on CMS's website, is 24 months. So you're all probably sitting there going, ooh, 24 months. That's a long time, but there's a backlog. I wish it would move faster. It's not moving faster, and that's an average wait time. Some practices wait 3 years. Some practices wait less than 2 years. But to get to the third level, you're going to wait, so be prepared. When you get an unfavorable decision on an appeal, whether it's any level, the first through really the fifth, you want to make sure that you are submitting appeals of those decisions on time. Be prompt. Submit copies of all documents that you want considered. You have to be complete, so if you're submitting anything, you don't have another chance to add to what you're submitting. That means whatever you've submitted, for example, on your second level appeal, is your opportunity to submit everything you would submit on your third level appeal or fourth level appeal. So you can't just keep changing the arguments and revisiting or improving your arguments as they go along. Think of every appeal as your best chance to put your best foot forward to appeal what Medicare is saying. You absolutely should submit any appeals via a trackable method, because Medicare loses things, as do its contractors, as do the administrative law judge. All of these entities, just for some reason, they're bombarded with appeals and things get lost. So send them in a trackable method. and make sure that you are following the appeal decision directions to a T. So when you have appeal rights in all of these letters, read what it says there. Make sure you are connecting all of the documents. You're listing the appropriate PTAN numbers and TIN numbers. You're including the right forms. If you're having an attorney submit this for the practice, you are going to have to execute what's called an AOR form, or an appointment of representative form, authorizing the attorney to act on the practice's behalf. If that form is not submitted, the AOR form, Medicare will reject the appeal and it will be considered late. So definitely, if you're working with a third party to submit an appeal, you want to submit that timely. Like I said before, when doing these appeals, you want to think about whether or not coding experts or statisticians or any other type of medical expert is going to be beneficial to you. I highly recommend, if it's a significant amount of overpayment requested, that you should obtain experts. Also, many professional liability insurance carriers do cover experts. So that's another reason why any type of initial determination should be referred to a professional liability carrier, because they will put you in the hands of a competent attorney, and they will put you in the hands of the proper, experienced experts who can help you. Obviously, I always recommend having practices consider getting any form of legal representation, because this is a very confusing process, very challenging, and certainly it's always better, in my opinion, to make it someone else's problem and not your own. Your practice is busy. Let someone else worry about filing Medicare appeals for you. So I did mention about the third level, the ALJ appeal. This is very important for you to remember, is that while that's ongoing, during that very long average period of time it takes to get before the ALJ, negotiations with Medicare remain open during that time. So if Medicare, although they're not going to recoup, in some instances they will, they'll try to recoup. You should object to any early recoupment while appeals are pending. Okay, you should object to any recoupments while appeals are pending. But while you are waiting for the ALJ level, if that is the route you'd like to go, which I would recommend, Medicare in the background wants its money. Okay, they still want their money. They'd rather have their money, or some money, than wait for an appeal, okay, or wait this lengthy process for the appeal. So you may be able to negotiate some type of settlement of the overpayment amount with Medicare during the pendency of the third level appeal. But I would simply refer back to my prior advice, which is sometimes settling is not always best. Sometimes paying money back can bite you in the rear end moving forward. So you should definitely consider on a cost-benefit basis whether that's a good idea for you or not. It is very hard to challenge a decision at the ALJ level. So while it is your best chance, while it is an impartial arbiter of the issues, and these ALJs are incredibly trained and skilled and competent, they know their stuff, okay? This isn't putting this in the hands of a judge who knows nothing about this stuff. They're actually very good. And the main offices for the ALJs are all over the country, with the two biggest in Virginia and California. But when the judge issues his decision, it is very unlikely that you will ever reverse it. So if an ALJ says, no, medical practice, you have done something wrong, and we do feel you should pay money back, and they may affirm in total, or they may affirm in part, reverse in part, they may remove part of the overpayment. Understand, if you have an administrative law judge looking at what you've billed Medicare and determining that some of it or all of it was improper, it is likely you're not going to win at levels 4 or 5, and you should then consider whether or not it's worth it to settle at that time. What can you do? So this is very daunting. What do we do? Medicare's Goliath, and we're David, and they want money back, and we did nothing wrong. Well, a good start to being proactive against an audit or against an overpayment is to have electronic medical records. It's a good way to have easy accessibility to complete records, making sure that all appropriate components of a patient's chart are in the EMR or uploaded into the EMR. Obviously, there are incentives with Medicare to using EMR as well. Personally, I'm actually not a fan of EMR as a healthcare lawyer, just because I think, as an aside, a lot of problems arise with them from a risk management perspective. But from a Medicare defense perspective, EMR is optimal. And then medical practices should be performing, in my opinion, with regularity, internal self-audits. In other words, whether or not Medicare is knocking on your door or whether or not they're sending you letters, having the forethought to enlist your biller or your coder or an outside coder to just take a look at a sampling of claims, making sure that they're properly submitted, making sure there's no problems with medical necessity. All of those measures on an internal, somewhat of a peer review, self-investigative process can only help. And they're not terribly expensive to do these self-audits, and it can end up saving you thousands and thousands of dollars on the back end. Because learning your own flaws, learning how billing is not being properly submitted will teach you to stop that practice, stop that process, correct, and move forward. So you essentially think of it like putting bandages on a wound, okay? Because we don't want to have bad billing practices or documentation practices persist. So I'm a big fan of the self-audit. Your billing staff, whomever that is, whether it's in-house or a separate company, should have proper training and qualifications to do their coding and billing as it relates to your practice's medical specialty. No two billers or coders are the same. Many times a biller or a coder has a particular area of focus. For example, there are podiatry coders, there are dermatology coders. Think about having a coder with specific training in your medical discipline. I am a big fan of having a certified coder because they are required to maintain their certification. They are up on all of the recent trends. These self-audits often can be performed by certified coders. So those types of analyses that happen within the four walls of the practice can help to train and educate your staff as a whole to make sure that documentation is complete. Are we using the right E&M codes? Is there anything else we need to do to make sure that these claims get paid? So I'm a big fan of the coder that is certified and conducting self-audits. And then any practice should keep on top of LCDs, or local coverage determinations, that are related to Medicare, which will help you stay up on the proper coding. Think of it like general rules and then sub-rules. The local coverage determinations are these sub-rules or exceptions to rules that Medicare expects every practice to know, but many practices don't stay up on them. And they are specific to different geographic zones. So the LCDs are an excellent tool for medical practice if they want to submit claims correctly. So these LCDs will issue coding guidance. They'll give you advice on how to properly document medical necessity. or any other important components of a medical record. So definitely stay on top of your LCDs. From a compliance perspective, some doctors don't like to hear this. Some medical practices don't like to hear this. Excuse me. But the Office of the Inspector General on its website, and there's some links that are at the end of this presentation for you. The Office of the Inspector General has a compliance plan for responding to audits right on its website. And essentially, because it's on the OIG's website, they expect you to follow it. So because it's there, doctors and medical practices are tacitly on notice of the right way to respond to audits versus the wrong way. So because the OIG was bold enough to put this on their website, doctors are expected to know it and follow it from a compliance perspective. Any practice should have proper and current coding manuals, whether it's within the practice if you're doing your own billing or in the hands of your outside billing companies, proper and current coding manuals. It is never a defense to an alleged overpayment for any doctor or practice to say, well, this is how I've been doing it for 15 years. No, it was never a problem. Or, well, all of my friends bill this way, so why am I getting criticized for this? Medicare doesn't care. Medicare doesn't care that things were going one way for 15 years and now they've changed. They don't care that your other colleagues are still billing the way you are. Unfortunately, it's like Russian roulette. They've drawn your name and your time is up and they want money back, whether it's justified or not. So having proper current coding manuals is optimal to make sure that you or your billing staff are staying abreast of not only proper coding, but any nuances that come out. And some coding manuals actually have an addendum that include LCDs, the local coverage determinations. And then I always recommend that a medical or dental practice keep and maintain an office policy and procedure manual. So I'm not referring to an employment manual, which I do think medical practices should have as well. I'm referring to a policy and procedure manual that a medical practice should have, which talks about all different things. How do we sterilize? How do we use injectables? How do we discard of samples? Also, how to respond to an audit. How to keep proper medical documents. How to train staff. How to submit records when an attorney subpoenas them, for example. But having a manual with policies and procedures, as well as a specific policy on what is to be done when there is an audit, is key, okay? Because more often than not, practices will tell me, oh, we didn't know that Mary Ann was going to do this, and then Josephine was doing that, and we duplicated records, we sent it in twice. Having a policy in place will help remove confusion. It will ensure communication. It will defray from any misunderstandings within the four walls of your office. Here are some links that I've mentioned or alluded to during the lecture today. These are links that will help you find out a little bit more about the appeals process or about the audit process. So, and there's even a link to the OIG, which I referenced before, which has a specific compliance plan on what to do, how to respond to audits properly. So and by the way, the last link is to my website, which I would simply refer you to because more often than not, we're posting information about these types of audits, okay, or information about Medicare. This is really not a shameless plug for my office. It's really just meant to have doctors and practices look there because you may find helpful advice on Medicare-related issues. So these links, obviously, I don't govern what's on these websites, but I can tell you some of these websites are not the most user-friendly. but I will certainly encourage you to try clicking on them, click around, try to gather information. You'll find the local coverage determinations for your geographic areas. You'll see trends in audits and appeals. So I would definitely make an important note for yourself that these are good resources to go to. And certainly, if anyone has any questions of me, I am done. So I'm happy to answer any questions. This is a very confusing process that goes on. So I would very much encourage you all, even if you think of questions following this presentation, to simply direct them to your association, and I'm happy to get back to you following today. But I don't see any questions, which means I have given an incredibly scintillating lecture. And I've answered all of them. But if anyone would like any more information, please let me know.
Somebody's typing now.
Oh, there we go.
Maybe
but by the way, while that individual is typing, there would mention to you all that what I have told you today about responding to Medicare audits, you can certainly use in your own practices with respect to responding to private health insurance audits. The same general processes apply. Obviously, there's a different appeals level per state, but as a general rule, you should have policies in place on how to respond to these. You should be timely. You should be saving your documentation. So certainly feel free to take what I've told you about the Medicare Mousetrap and parlay it into your own experiences with private health insurance carriers.
Okay, Nan, I don't think we have any questions today. I thank you very much for your time and for your presentation. I want to thank all of our participants for joining. This concludes our webinar, and thank you for your participation. Have a great afternoon.